Good evening, everyone. Myself, Dr. Prafula from Market Center AIMS, and I'll be discussing this topic if HEDS is still valid. So, the answer to this question lies in the question itself, how I'll explain in my concluding slide. Now, HEDS, I'm not going to the details of this trial, but yes, I'll just pick the points, the questions that HEDS attempted to answer, and if these are relevant to us in our current practice. The first question that HEDS attempted was if topical steroids are effective in treatment of HSB stromal keratitis along with topical trifluridine. The study included 106 patients and one group received 10 weeks tapering dose of topical prednisolone, the other received placebo. And at 16 week, it was noted that topical prednisolone led to better resolution, faster resolution, reduction in progression of stromal keratitis, and also fewer treatment failure, even though the visual acuity at 6 months was similar in both the group. So the authors concluded topical steroid is effective in treatment of HSV stromal keratitis. And if it is useful to our practice, yes, definitely. Everybody knows topical steroids are the treatment of choice for stromal keratitis. But 2 points need to be discussed here. One, trifluridine was the only drug available at that point of time. But now we have better drugs like acyclovir and ganciclovir, which should be used. Second, a uniform regimen of 10-week steroid taper should not be followed in all patients, because the authors themselves they noted that within 6 weeks of cessation of corticosteroid, the treatment failure rate becomes similar in both the group, largely because few of the patients were tapered off steroid quite early. So individualize your treatment depending on the clinical response. You should taper the steroid. The second question was if oral cyclovir to be added along with topical steroid and trifluridine in meninoma stromal keratitis. Well, it included 104 patients, and one group received oral acyclovir 400 milligram 5 times daily for 10 weeks. The other received placebo, and at 6 months, no difference was found between the two groups. So the authors concluded oral cyclovir has no benefit in addition to topical antiviral in HSV stromal keratitis. Now, few points need discussion here. First, do we read antiviral in stromal keratitis since most stromal keratitis are immune mediated? The answer is definitely yes, because if you don't give antiviral cover, there is a potential chance of uh, recurrence of viral keratitis and prolonged viral shedding. The second question is if antiviral has to be given, whether topical or oral. The answer lies in the report by American Academy of Ophthalmology on treatment of HSB keratitis, where they found that oral antiviral agents are better than topical antiviral agent because of the better safety profile and superior corneal penetration based on the available pharmacokinetic studies. Third part which HEDS couldn't address is how to treat HSB keratitis, where stromal and epithelial component both are there. The HEDS had only 9 and 12% of patients with this disease, so you cannot manage a case of this based on your HEDS guidelines. The third question was if oral acyclovir helps in better resolution of iritis. However, I am not going to discuss this because this trial was terminated because of very few patient enrollment in the study. The fourth question was if early treatment of HSB epithelial keratitis with oral acyclovir prevents the blinding complications of stromal keratitis and iridocyclitis. It included 287 patients. Oral acyclovir 400 milligram 5 times per day was given for 3 weeks within 7 days of onset of symptoms, and the other group received placebo. At 1 year, the incidence of stromal and keratitis and iridocyclitis was similar in both the group. So no benefit was found of adding oral acyclovir. The fifth question was if low dose oral acyclovir prophylaxis is effective in preventing recurrence of HSV eye infection in patients with previous episode of herpetic eye disease. Well, this is probably the most important outcome of HEDS trial, where they found that if you give oral acyclovir 400 ml twice a day for 1 year, it leads to reduction in the recurrence of HSB keratitis by almost 50%. Is it relevant to us? Definitely yes. Most corneal practitioners, they follow this protocol. However, one point to discuss here is how long one should continue with this prophylactic dose, because the author themselves found that once they discontinued this prophylactic therapy, within 6 months, the recurrence rate became similar in both the group. So how long to continue? Well, probably one has to individualize this and depending on the other eye status, amount of scar, following every episode of stromal keratitis and encroachment onto the visual axis, and then individualize the treatment depending on the patient's condition. However, at least 1 year of therapy must be there for all patients of stromal keratitis. The sixth question was, if previous HSV-I disease affects the recurrence of HSV keratitis. Well, the answer to that was, if the patient had epithelial keratitis, not going to affect or increase the risk of epithelial keratitis, but patient with stromal keratitis had almost tenfold increased risk of having a recurrent stromal keratitis, and the demographic variables had no role in recurrent HSV keratitis. This is important for us because if you are treating a patient of HSV stromal keratitis, you have to counsel the patient about recurrency and you have to keep a close follow-up. Question 7 was, if factors like UV light or corneal trauma or stress increases the recurrence of HSV-I disease. Well, the authors included 308 patients in that. However, a valid response could be obtained in only 35 patients. So the statistical analysis, the authors found all these factors are not relevant, but this has to be taken with a pinch of salt because the number of patients included is very small. And secondly, all these factors are known to induce recurrence in other form of HSV infection like orofacial genital. And thirdly, corneal trauma. As there are several reports, one I have already highlighted, HSV keratitis can recur following phototherapeutic keratectomy. Thus, surgical trauma can lead to recurrence, which heads couldn't find. So all these results needs further studies. In addition to that, HEDS excluded all patients of pediatric keratitis. Those while managing pediatric keratitis, you cannot rely on HEDS. Also, it excluded endothelitis, and HEDS never addressed patients of herpetic eye disease undergoing keratoplasty or cataract surgery. Again, newer antivirals have come up, and topical treatment should be avoided. And if you see this table by Kalijic et al., you will find Acyclovir, Famciclovir are more patient friendly compared to Acyclovir. Thus, if HEDS is still relevant, definitely yes. And as I said, the answer lies in the question itself, because after 30 to 40 year of publication of this trial, we are still discussing this trial because this trial is still relevant. But certain factor you have to consider while applying the principle of HEDS. First, consider new antiviral. Secondly, individualize the steroid treatment protocol for your patients. Third, when treating with pediatric HSB keratitis or endothelitis or necrotizing keratitis or epithelial and stromal keratitis, or patients undergoing keratoplasty with herpetic eye disease or patient undergoing cataract surgery, you have to rely on the result of other studies, although you can still use the basic core principles of this HEDS trial. With this, I'll conclude my talk. Thank you for your kind attention, and thank you, Kerakon, for giving me this opportunity. Thank you very much.